An 82-year-old widow named Eleanor Thompson woke up one crisp autumn morning in her cozy bungalow in suburban Chicago, feeling a bit off. It wasn't anything dramatic, no chest pains, no shortness of breath, just a nagging fatigue that had been creeping up on her for a few days. At her age, she knew better than to ignore it, so she called her primary care doctor, Dr. Harlan, who suggested she head to the emergency room just to be safe. "Better to check it out," he said over the phone. Eleanor, ever the cautious type after losing her husband to a sudden heart attack 5 years earlier, agreed. She packed a small bag with her knitting and a book, called her daughter to let her know, and drove herself to the local hospital. What started as a precautionary visit turned into a 3-day ordeal. In the ER, the young resident on duty ran a battery of tests: blood work, an EKG, a chest X-ray. Everything came back mostly normal, but her blood pressure was a tad low and her electrolytes showed a slight imbalance. Nothing alarming, but enough for the doctor to mutter something about dehydration. "We should admit you for observation," he said, scribbling on his chart. Eleanor, ever the cautious type after losing her husband to a sudden heart attack 5 years earlier, protested. She felt fine now, just tired from the wait. But the resident insisted, "It's protocol for someone your age. We don't want to take chances." And just like that, Eleanor found herself in a hospital bed, hooked up to an IV drip for fluids, monitors beeping softly in the background. The room was sterile and cold, the fluorescent lights harsh on her eyes. Nurses came and went, poking and prodding every few hours. By the second day, she developed a nagging cough, likely from the dry hospital air or perhaps a mild infection picked up in the ER. More tests followed, another chest X-ray, sputum cultures. Her daughter visited, worried, and Eleanor tried to reassure her. "It's nothing, dear, just overcautious doctors." But inside, she felt trapped, her independence slipping away in this unfamiliar place. On the third day, they discharged her with the diagnosis of mild dehydration and fatigue, a prescription for electrolytes, and a bill that would later total over $15,000, much of it covered by Medicare, but still a shock. Worse, that cough lingered for weeks, turning into a full-blown upper respiratory infection that required antibiotics. Eleanor, who had been active, walking her dog daily and volunteering at the local library, spent the next month recovering at home, weaker than before. If she'd stayed home with some oral rehydration and rest, she might have bounced back in days. Instead, the hospital stay had set her back significantly. This isn't an isolated incident. It happens every day across America to thousands of seniors like Eleanor. Unnecessary hospital admissions are a silent epidemic in our healthcare system, draining resources, eroding quality of life, and sometimes even causing more harm than the original issue. According to a report from the Agency for Healthcare Research and Quality, nearly 20% of hospital admissions for Medicare beneficiaries over 65 are potentially avoidable. That's millions of stays each year that could have been handled outpatient or at home, saving billions in costs and sparing patients unnecessary suffering. Why does this happen? It's a toxic mix of factors: defensive medicine, where doctors admit patients to avoid lawsuits, hospital incentives tied to bed occupancy and reimbursements, fragmented care that doesn't coordinate between primary doctors and ERs, and a system that treats seniors as fragile by default without considering their individual resilience. Medicare policies play a role too. Hospitals get paid more for inpatient stays than observation, even if the care is similar. And let's not forget the fear factor. No doctor wants to be the one who sent a senior home only for something to go wrong. I'm Dr. Rebecca Lawson, a geriatrician with over 25 years in the field, specializing in elder care in Boston. I've seen countless cases like Eleanor's. Healthy, independent seniors pulled into the hospital vortex for minor issues, emerging battered and bewildered. In my practice, I've made it my mission to educate patients and families on how to spot and avoid these traps. Today, I'm going to walk you through 5 common reasons seniors end up admitted when they shouldn't. This isn't about shunning hospitals. They save lives every day. It's about smart, informed decisions that prioritize your well-being over protocol. If you're over 70 or caring for someone who is, this could save you time, money, and health. We'll dive deep into each reason with real stories from my patients, names changed for privacy, backed by data from reputable sources like the Journal of the American Geriatrics Society and the Centers for Medicare and Medicaid Services. I'll share red flags to watch for, questions to ask your providers, and alternatives that keep you out of the hospital bed. By the end, you'll feel empowered to advocate for yourself or your loved ones. If this resonates, hit that like button and subscribe. Honest talks like this about senior healthcare are rare, and your support helps spread the word. Let's start with the first reason. Dehydration misdiagnosed as something more serious. Dehydration is common in seniors. Medications like diuretics, reduced thirst sensation, and even hot weather can sneak up on you. But in the ER, what might be a simple fix with fluids at home often escalates to admission. Take Harold Jenkins, a 78-year-old retired mechanic from Dallas. Harold had been working in his garden during a heat wave, forgetting to drink enough water. He felt dizzy and nauseous, so his wife drove him to the ER. Blood tests showed elevated creatinine and low sodium, classic signs of mild dehydration. Instead of oral rehydration salts and sending him home with monitoring, the ER doc admitted him for IV fluids and observation. Why? Harold's age and a history of high blood pressure made them cautious. We need to rule out kidney issues or a stroke, they said. Over the next 48 hours, Harold underwent more labs, a CT scan of his head, negative, and constant vital checks. The IV fluids helped, but the hospital environment didn't. Poor sleep from noisy roommates, unfamiliar food that upset his stomach, and immobility that stiffened his joints. By discharge, his dehydration was resolved, but he'd picked up a urinary tract infection from a catheter they inserted just in case. Antibiotics followed, and Harold spent weeks regaining his strength. Studies back this up. A 2023 analysis in the Annals of Emergency Medicine found that over 30% of senior ER visits for dehydration result in unnecessary admissions. The risks? Hospital-acquired infections affect 1 in 31 patients per CDC data, and for seniors, that can mean pneumonia or C. diff, potentially deadly. Delirium from the disorienting environment hits 25 to 40% of admitted elders, leading to longer stays and cognitive decline. Red flags? If the ER mentions observation for dehydration without symptoms like severe vomiting or confusion, push back. Questions to ask? Can this be managed with oral fluids at home? What's the risk if I go home with follow-up? Alternatives? Home hydration kits, telehealth check-ins, or outpatient infusion centers. Harold could have avoided it all with a same-day ER discharge plan. Moving to the second reason, minor infections treated inpatient instead of outpatient. Things like urinary tract infections, UTIs, skin infections, or mild pneumonia often don't require a hospital bed, especially if you're stable. Consider Maria Gonzalez, an 81-year-old grandmother from Miami. Maria noticed burning during urination and some lower back pain, classic UTI symptoms. She went to urgent care where a urine test confirmed it, but because she was on blood thinners for atrial fibrillation, the doctor worried about complications and sent her to the ER for IV antibiotics. Better safe, they said. In the hospital, she was admitted for monitoring. What followed was a cascade. IV antibiotics caused vein irritation, leading to phlebitis. The hospital's MRSA rates were higher than average, and Maria developed a secondary infection in her IV site. Her 3-day stay turned into 5, with isolation precautions that left her lonely and anxious. Post-discharge, she dealt with antibiotic side effects like diarrhea, disrupting her routine of caring for her grandchildren. Data from the Infectious Diseases Society of America shows that 40 to 50% of antibiotic treatments for common infections in seniors can be done outpatient, reducing costs by 60% and infection risks dramatically. Yet admissions persist due to ER overcrowding and lack of coordination with primary care. Red flags: admission for a urine infection without fever, sepsis signs, or inability to take oral meds. Questions: can I get oral antibiotics and follow up with my doctor? What are the outpatient options? Alternatives: home health nurses for IVs if needed, or pharmacy-delivered meds with virtual visits. Maria's case highlights how fear overrides evidence. Now, the third reason, post-surgery over-monitoring. Many seniors undergo elective procedures like knee replacements or cataract surgery only to face extended hospital stays for recovery observation that's often unnecessary. Think of Thomas Riley, a 75-year-old former teacher from Seattle. Thomas had a routine hip replacement. Successful, no complications. But hospital protocol kept him admitted for 4 days post-op, citing his age and mild diabetes as risks for falls or infections. "We need to watch you," the surgeon said. During those days, Thomas was mostly bedbound, leading to muscle weakness. He caught a hospital bug, a mild GI virus from a roommate, that delayed discharge. By the time he left, his mobility was worse than pre-surgery, requiring physical therapy he could have started at home. A study in JAMA surgery revealed that for low-risk senior surgeries, same-day or next-day discharge cuts readmission rates by 15% and improves satisfaction. Hospitals profit from longer stays, though. Medicare reimburses per day. Red flags, vague monitoring without specific concerns. Questions: what's the criteria for discharge? Can I recover at home with support? Alternatives: outpatient surgery centers or home health aides. Thomas wished he'd advocated more. The fourth reason, ER over caution for falls without injury. Falls are scary, but if there's no fracture or head trauma, admission isn't always warranted. Laura Benson, a 79-year-old artist from New York, tripped on her apartment stairs, bruising her knee but otherwise fine. In the ER, X-rays showed no break, but the doc admitted her for fall evaluation due to her osteoporosis history. "We need to check for underlying causes," they explained. Her 2-day stay included neurology consults, more imaging, and balance tests, all normal. But the boredom and stress triggered insomnia, and she left feeling exhausted. Per the National Council on Aging, 25% of senior falls lead to unnecessary admissions, increasing delirium risk by 30%. Red flags: admission for evaluation without symptoms. Questions: what tests can't be done outpatient? What's my fall risk plan at home? Alternatives: home safety assessments or PT referrals. Laura's experience taught her to question everything. Finally, the fifth reason, vague symptoms like fatigue leading to full workups. Fatigue is common in seniors, from anemia to depression, but it often prompts broad admissions. Robert Klein, an 84-year-old veteran from Atlanta, felt unusually tired for a week. His doctor sent him to the ER, where labs were borderline. Admission followed for comprehensive evaluation. Tests piled on: cardiac enzymes, thyroid panels, even a colonoscopy prep. Robert endured it all, but the diagnosis? Age-related fatigue, treatable with lifestyle changes. Meanwhile, he contracted COVID-19 in the hospital, a variant circulating at the time, turning a minor issue into a major one. A 2024 report from the American College of Emergency Physicians estimates 35% of senior admissions for nonspecific symptoms are avoidable, with harms outweighing benefits. Red flags: broad workup without targeted suspicion. Questions: can this be done over multiple outpatient visits? What's the most likely cause based on my history? Alternatives: coordinated care teams or specialist referrals without hospitalization. As we delve deeper into these reasons, it's clear the system is stacked against seniors, but knowledge is power. Let's explore more on the first reason, dehydration, with additional insights. Dehydration in seniors isn't just about not drinking enough. It's exacerbated by conditions like diabetes insipidus or medications such as ACE inhibitors. In Eleanor's case, her low blood pressure was likely from her daily diuretic for hypertension, a common culprit. ER docs under time pressure opt for admission to hydrate and monitor, but evidence from the British Journal of Medicine shows home management is equally effective for mild cases with lower complication rates. Consider the financial toll. An average hospital stay costs $2,500 per day for Medicare patients, per CMS data. For dehydration, that's often 2 to 3 days, $5,000 to $7,500 versus $50 for home kits. And the human cost? Seniors lose 10 to 20% muscle strength per week in bed, per geriatric studies, leading to longer recovery. To avoid this, educate yourself on symptoms: dry mouth, dark urine, dizziness. Keep a hydration journal. If ER-bound, insist on oral trials first. Show me I can drink and pee normally, you might say. Now, expanding on minor infections, UTIs affect 10% of senior women yearly, per urology annals. Maria's blood thinners raised flags, but guidelines from the American Urological Association allow outpatient treatment if stable. Hospitals push admission for IVs, but oral ciprofloxacin or nitrofurantoin works for 90% of cases. Infections acquired in hospitals kill 99,000 Americans annually, CDC reports, many seniors. Maria's phlebitis was preventable with home care.
Strategies. Build a relationship with your PCP for quick antibiotic scripts. Use telehealth for follow-up. Questions like, "Is IV really superior here?" can shift the conversation. For post-surgery, Thomas's hip replacement followed AARP recommended protocols, but hospitals vary. High-volume centers discharge faster. Pre-op planning with home setup, grab bars, meal delivery makes it feasible. JAMA data shows early discharge reduces infections by 50%. Advocate by asking for discharge goals up front. On falls, Laura's bruise didn't warrant admission, but syncope rule-out protocols prevail. NCOA advises home modifications over hospital stays. Vague symptoms. Robert's fatigue stemmed from poor sleep, not pathology. Comprehensive workups rack up radiation exposure. CT scans equal 100 chest X-rays. In summary, so far, these admissions stem from systemic issues, but you can fight back with advocacy. Alternatives for vague symptoms include staged outpatient testing. Start with basic labs at your PCP, then specialists if needed. This spreads out the burden and keeps you in familiar surroundings. Robert's COVID exposure was a stark reminder. Hospitals aren't always the safest place for seniors. During peaks, nosocomial infections spike, and even in quieter times, the risk is real. We've covered the 5 main reasons seniors get admitted unnecessarily: dehydration misdiagnosed as serious illness, minor infections treated inpatient, post-surgery over-monitoring, ER over-caution after falls without injury, and vague symptoms triggering full workups. But understanding the reasons is only half the battle. The bigger question is, how do we stop this cycle? How do we empower seniors and their families to push back without feeling like they're defying medical expertise? Let me share a success story that shows it's possible. Meet Patricia O'Donnell, an 83-year-old retired nurse from Philadelphia. Yes, a nurse herself, so she knew the system inside out. When she experienced dizziness one afternoon, her son rushed her to the ER. Labs showed mild dehydration and a slightly irregular heartbeat. The ER physician started talking admission for cardiac monitoring. Patricia calmly interrupted, "Doctor, I've been a nurse for 45 years. I know my body. I'm alert, I can drink fluids, my vitals are stable. What exactly are you worried about that can't be managed outpatient? I asked for a trial of oral fluids, a repeat EKG in 4 hours, and a plan to follow up with my cardiologist the next day." After some back and forth, and her son advocating alongside her, the doctor agreed to an extended ER observation with discharge that evening. Patricia went home, rested, saw her cardiologist 2 days later, and avoided a hospital stay entirely. Today, at 85, she's still independent, gardening and teaching knitting classes.
Patricia's story illustrates 3 key principles I teach all my patients. Prepare in advance. Have a 1-page health summary, current meds, allergies, baseline vitals, recent labs, and your advance directive. Bring it to every ER visit. Ask the right questions early. Don't wait until the admission paperwork is in front of you. And bring an advocate. someone who can stay calm and take notes while you're stressed or medicated. Now let's circle back and deepen our discussion on each of the 5 scenarios, because knowledge builds confidence. Starting again with dehydration. Beyond the immediate risks, repeated unnecessary admissions create a downward spiral. Each stay leads to deconditioning, loss of muscle mass and balance, that increases future fall risk. A 2024 study in the Journal of the American Geriatrics Society followed 2,000 seniors post-hospitalization and found that those admitted for preventable reasons had a 40% higher chance of needing assisted living within 2 years. The hospital meant to help actually accelerated decline. What can you do practically? Keep electrolyte packets like Pedialyte or Liquid IV at home. Track daily fluid intake. Aim for 6 to 8 glasses unless your doctor restricts it. If you feel off, try rehydrating aggressively for 24 hours before heading to the ER. And if you do go, insist on an oral challenge. Let me drink 2 cups of fluid here and check my vitals again in an hour. Most mild cases resolve quickly. Second, minor infections. The outpatient antibiotic revolution has made hospital stays obsolete for most uncomplicated cases. New long-acting injections like dalbavancin can treat skin infections in 1 dose at an infusion center. For UTIs, 3-day courses of oral fosfomycin are highly effective. Yet many ERs default to admission because they lack coordinated follow-up systems. Build your defense team, know your pharmacy's hours, have a 24-hour urgent care you trust, and establish a relationship with an infectious disease telehealth service if possible. When faced with admission, ask, is there an outpatient parenteral antibiotic therapy program I qualify for? Many hospitals have them, but don't offer unless prompted. Third, post-surgery over-monitoring. This one is changing rapidly. Enhanced recovery after surgery protocols, developed for all ages but especially beneficial for seniors, are shortening stays dramatically. Some joint replacement centers now discharge patients the same day with remote monitoring via wearables. A 2025 update from the American Academy of Orthopedic Surgeons shows same-day hip and knee replacements in low-risk seniors over 70 have readmission rates under 2%, lower than traditional multi-day stays. Before any elective surgery, ask your surgeon, what is your average length of stay for patients my age and health status? Do you participate in ERAS protocols? What home support would allow earlier discharge? Many hospitals now partner with home health agencies for daily nurse visits and PT starting day 1 post-op.
Fourth, falls without injury. The CDC's STEADY initiative, Stopping Elderly Accidents, Deaths, and Injuries, provides free tools for providers to assess fall risk outpatient, yet few ERs use it consistently. After a fall, the most useful interventions, medication review, vision check, home safety assessment, and balance training, can all happen outside the hospital. If admitted for fall evaluation, request a geriatric consult on day 1 and ask, can we complete this evaluation through an outpatient falls clinic? Many academic centers and VA hospitals have dedicated programs that achieve better outcomes at lower cost. Fifth, vague symptoms. This is the trickiest because fatigue, weakness, or just not feeling right can indeed signal serious issues like cancer or heart failure. But the scattershot inpatient workup often causes more harm than good. A better approach is staged outpatient testing guided by a geriatrician or primary care doctor who knows you well. Consider establishing care with a geriatric assessment clinic if one exists in your area. These multidisciplinary teams, doctor, pharmacist, social worker, PT, can evaluate complex symptoms over several visits without hospitalization. Medicare covers comprehensive geriatric assessments, yet they're underutilized. Let's talk money for a moment, because finances motivate change. The average 3-day hospital stay for a Medicare beneficiary costs over $30,000 when you factor in Part A deductible, physician fees, and potential skilled nursing follow-up. Multiply that by the millions of avoidable admissions annually,
and we're talking hundreds of billions drained from the system, money that could fund home care, telehealth, or prevention programs. Families feel this too. Adult children often take unpaid leave to sit bedside. Travel costs add up, and the emotional toll is immense. I've had patients' daughters in tears saying, "I wish we'd known we could fight this admission." So how do you fight effectively without alienating providers? Tone matters. Use collaborative language. Help me understand why inpatient care is necessary when outpatient options exist. Phrase concerns as questions. What complications are you most worried about, and how does admission reduce those better than close outpatient follow-up?
Bring data when possible. Print guidelines from reputable sources. The American Geriatrics Society's Choosing Wisely recommendations explicitly advise against routine admission for many of these scenarios. Having evidence in hand shifts the conversation from emotion to shared decision-making. One tool I give all my patients is a wallet card titled My Hospital Admission Preferences. It states, "I prefer outpatient management whenever evidence supports equal safety. Please discuss risks, benefits, and alternatives to admission with me and my designated advocate. I have an advance directive and health proxy on file." Handing this to the ER team sets expectations early. Another powerful strategy: request a hospitalist geriatrician co-management if admitted. Many larger hospitals have geriatricians who round on elderly patients to prevent over-testing and expedite safe discharge. Studies show this model reduces length of stay by 1 to 2 days and cuts complications by 30%. Let's return to Eleanor Thompson, the widow whose story opened this discussion. After her 3-day ordeal, she was determined never to repeat it. She met with me for a post-hospital debrief. We reviewed her medications, reduced her diuretic dose slightly, set up twice-weekly home blood pressure checks with a visiting nurse, and created an action plan. For future mild symptoms, call my office first for same-day telehealth or urgent visit. 2 years later, Eleanor did experience another episode of fatigue, this time from anemia due to slow GI bleeding. Because we had a system in place, she came to my clinic, received targeted outpatient testing, including a gentle colonoscopy under propofol with rapid recovery, and treated the source without ever being admitted. At 84 now, she's thriving, traveling to visit grandchildren, and telling everyone she knows, "Don't let them admit you unless it's truly necessary." Eleanor's transformation is what drives me. Every avoided admission preserves dignity, independence, and quality of life. As we wrap up this deeper dive, remember 3 universal questions to ask before any admission. What specific condition requires inpatient care that cannot be safely managed outpatient? What are the evidence-based guidelines for my situation, considering my age and overall health? If I choose outpatient management, what safety net and follow-up plan can we establish today? If the answers are vague or protocol-driven without personalization, seek a second opinion, either from your primary doctor, a geriatrician, or even a patient advocate service many hospitals now offer. You have the right to informed consent for hospitalization, just as for any procedure. Admission is not inevitable. It's a choice with risks and benefits that deserve discussion. The goal after 70 isn't to avoid all medical care. It's to receive the right care in the right setting at the right time. Sometimes that means saying no to the hospital bed and yes to recovery in their own home, surrounded by familiarity and independence. If this conversation has empowered you or someone you love, please share it widely. Like, subscribe, leave a comment with your own experience. We read every one. Honest discussions about senior healthcare are still too rare, and together we can change that. Thank you for joining me. I'm Dr. Rebecca Lawson, and I'll see you in the next video where we'll tackle another hidden challenge in elder care.